the most difficult cases in derisicaris hemoptysis. Now, why would a person in hemoptysis die? Why do you think a person in hemoptysis dies? Is it
high ventilation problem.
So what she says is it's probably exsanguination or is it hypoxemia? The question is it exsanguination or is it hypoxemia? What kills the patient? Is it a respiratory problem or is it a hemorrhagic problem? You understand? Now, hemoptysis is a situation where blood is coming out. So is he going to die of blood bleeding or is he going to die of hypoxia? So he's not going to die of bleeding. They don't exsanguinate as quickly, but they die of actual hypoxia. You understand? So when you actually talk about a person having severe hemoptysis, okay, you can characterize it by two ways. One is to characterize it by the amount of distress you have versus the amount of blood that is coming out. Now, amount of blood that is coming out is always a problem. I am comfortable with a patient who is in front of me and coughing out blood. I am very comfortable with that patient who is in front of me, fully conscious, and he is coughing out blood. Now, why is that comfortable for me? Because I know the quantity of blood coming out. Now, contrast this to a patient who is bleeding inside and not coughing out the blood. That patient will actually manifest with the respiratory rate going higher and higher and higher and higher. Then will manifest as distress and then will go down. You understand the basic difference? Okay, if a person is coughing out blood, I know, okay, this much is coming out. That's why what we say, if there is a patient who's having hemoptysis, ask the patient to cough out the hemoptysis into a container and monitor the amount of blood coming out in that. Anything more than 200 ml, actually warrants emergency management. Anything more than 200 ml would actually warrant emergency management. So if you look at definitions across, it could be 200, could be 600, could be 1000. There are definitions across. But that definition is not, it's a statement made by somebody कि ऐसा भी हो सकता है, वैसा भी हो सकता है. But what you understand clearly is, it could be 200, it could be 500, it could be 600. Once distress comes in, you are in the category of severe hemoptysis. Are you understanding? Is it clear now?
Is 200 in a bout?
No, in the 24 hours. So that's a very important question. Is it in one bout? No, it's not. So in the event, that's why we say keep the receptacle visits the patient. That's what I told also, not keep collecting the blood. So every time you keep collecting the blood, the receptacle become bigger with more amount of blood. Are you understanding? And that will tell you, okay, ये 200 ml तक पहुंच गया है. I need to quickly investigate. This patient may now go into, because the distress that will occur suddenly. He is going to aspirate. So I am happy with a person. First of all, clinically understand this. If I have a patient who is having hemoptysis and the patient is coughing in front of you and is getting out that sputum, no matter how bad he looks, if he's when they're spitting sputum, it looks bad, no? It looks very gory. It looks like a horror story, isn't it? But when they are coughing out the blood, it will, at least since he's coughing out the blood, you can actually monitor the amount of blood that is coming out. So you are comfortable compared to a person who comes in with distress. So the decision to actually go ahead quickly would actually depend on this. So if the person is actually having distress, there is no time. There is really no time. If he is having distress, we have to as quickly as possible, go and secure that bleeding. Are you clear? Am I clear on this till now? Is everything clear here till now? Okay. That if there is distress, if the distress has started coming, I don't know. I don't have the time. I don't want to look at this patient. If the distress comes in, that is the RR is more than 90, patient is visibly looking sick, patient is visibly looking distressed, there is no time. You have to quickly go and solve the problem. Okay, so say a patient comes into you and he is vomiting out blood, is spitting out blood. Okay, it's not vomiting, it's spitting out blood. What are the investigations you'd like to do? So, Amit, what investigations you'd like to do?
First of all, chest X-ray, coagulation studies.
Yeah, so in coagulation studies, you have to be clear what it is.
PTNR.
I will send PTNR, I will send PTT, I will send fibrinogen, I will send all three. In CBC, I will send the CBC. I need the CBC. What I need in the CBC? What am I looking at in the CBC? And why am I looking at hemoglobin?
Because he is bleeding.
So what are you looking at the coagulation factors for?
Is there any coagulation disorder?
So and then what if you have this coagulation disorder, what are you going to look at? Then what are you thinking inside the lungs? If you're looking at a coagulation disorder, what are you looking at inside the lungs? So you're right, coagulation disorder. But what are you looking at inside the lung? What is the pathology there?
Alveolar hemorrhage.
Diffuse alveolar hemorrhage. Okay, if the INR is deranged, if the PTT is deranged, you're looking at diffuse alveolar hemorrhage. It's very important. Okay, diffuse alveolar hemorrhage can't be treated otherwise. You need different other things to do with diffuse alveolar hemorrhage. It could be leptospirosis, it could be anything like that. You understand? It could be vasculitis. So once you see coagulation abnormality, you should start looking at diffuse alveolar hemorrhage. That's the diagnosis that's going to come in your mind. Diffuse alveolar hemorrhage. CBC for what are you looking at?
Maybe for hemoglobin, if it is bleeding massively, hemoglobin drops.
Okay, but as I told you, we are not looking at that exsanguination. To bleed massively, you need to drop your hemoglobin, you need 500 to 1000 ml of loss. That is, you are beyond that. You are not really looking at your CBC for hemoglobin. You understand? Because if you have gone beyond 200 cc, you are looking at severe hemoptysis. Patient will not be sitting in front of you. We should already be getting evaluated, right? So HB, ठीक है. Then what are you looking at? You just said CBC. See, whenever you are sending an investigation, you don't send it blindly. You send it with an intention. What I'm looking for. Remember this all your life, okay? All your life. If you send investigations, HB, CBC, LP, RTA, means you don't know what you're doing. You don't know what you're doing. You have to send an investigation based on what you are expecting to see. So remember this, whenever you're sending an investigation, you have to look at, okay, I'm going to look at this, maybe I might find this, that's why I want to do this. If you think like that, then you will understand pathophysiology, then you'll understand the importance of the investigations, you'll understand why to follow them up. Okay, if you just send it and then try to hope to find something in that, that is not good medicine. That is not clever medicine. Okay, to the extent that when we were all studying, investigations was something that were hardly being sent. We clinically used to see a patient and then we used to send one investigation, 2 investigations maximum, and with that we used to get an answer. Isn't it? It was always like that. You don't resort to investigations first and then go there. So CBC.
Platelets.
Why the platelets?
So thrombocytopenia,
So any reason to cause vasculitis and diffuse alveolar hemorrhage will actually reflect with the platelet count that is going to be on the lower side. Okay, low platelet counts. Okay, low platelet count. Then in the CBC, what else? The WBC count. Why are you worried about the WBC count? So which kind of infections would cause this kind of hemoptysis? So pneumonias, which are cavitatory in nature, which are necrotizing in nature, has a high chance of having hemoptysis. Okay, they might come up with blood. Cavitatory necrotizing pneumonias, which can come with lobar pneumonias. Specifically in young individuals, when they come in, they are MRSA pneumonias. When they come in young individuals, okay, they come with MRSA pneumonia. And so MRSA pneumonia is something you try to rule out at that time. Klebsiella can also cause necrotizing pneumonias. Okay, pneumonia. Then what are you looking at apart the CBC? In the CBC, what else are you looking at? Come on, you're still in the CBC. Lymphocytes. Why? COX, yeah. I want to look at COX. So there's one more investigation I'd like to do with CBC. When you say CBC, one more investigation come in your same breath. What is that? When you say CBC and hemoptysis, one more investigation come in your the same breath. CSR. Okay. The moment you talk about CBC, you talk about ESR. Okay. ESR is elevated usually in these cases of infective origin, specifically tuberculosis. So when you're looking at hemoptysis, you will start thinking CBC, ESR, CRP, and coagulation profile. Right? Right? What else investigation Supriya would like to do? So he did talk about laboratory investigations. Is there any other investigation you'd like to do?
Chest X-ray.
So yeah, so your chest X-ray. Now, what is the why do you want to do a chest X-ray? Why? What is the reason?
So baseline chest X-ray. Other thing we can also see if pneumonitic patches there.
So more than a chest X-ray, I would like to do a CT scan. Okay, an HRCT is more important than a chest X-ray. And why is that so? Because see, if I have an HRCT, I would go towards diagnosis more often. If I have an HRCT with a contrast, I have more diagnosis in place. HRCT, and if the patient is having severe hemoptysis, patient says, "मैं कम से कम 200-300 ml ऐसा निकला है मेरे हाथ से," I will do a CT angio only. You understand? Why would I do a CT angio? Because if there is a blush which I am seeing, that is an artery that is bleeding, the person who's doing an interventional radiology will actually know, or the bronchos will know that this is from where the problem is coming. So that's why your investigation would be, the choice would be CT with CT angio. Are you understanding? In the event that the bleeding is on the heavier side, it's not necessary that if the bleeding is there would be CT angio showing that bleeding. Okay, the CT angio will show the bleeding only when the bleeding is higher, when the bleeding is active. If the person has stopped bleeding, CT angio will not show you anything. Are you understanding? It will not show you anything at that moment, right? Huh? Okay, so now you did a CT angio. What is the next thing you'd like to do, Sachin? If you want this patient is in front of you, what is the next thing you'd like to do? Say the patient has started having hemoptysis again, and there is more than 100 ml of blood coming in. What will you do? You are in that situation where the patient doesn't look. It looks like you have to intervene. You have to intervene. So you have the option of going in for surgery. You have the option for going in for bronchoscopy. You have the option of going in for angiography. Okay, what would you do? You have already done a CT scan. And the CT scan you find left side if there is a small opacity that is there on the left side. What would you do?
So first of all, we need to control the bleeding is there to control. Further, we can go for bronchoscopy.
So no. So you will never go for bronchoscopy. The answer is always angiography. They are not CT angio. The answer is always conventional angiography, interventional radiology. When you do a bronchoscopy, if you put a bronchoscope inside, you will not be able to see anything because it will be only blood. It will be only blood. So bronchoscopy is the last procedure I'd like to do in these cases. It will not be done only. In fact, it's never done. Okay, the bronchoscopy can be done only when there is no blood. The moment you put a scope, you'll find blood inside. You can't see anything. Are you understanding? So you can't do with bronchoscopy anything. That is why the answer is to have intervention radiology team stand by. So in the event that there is bleeding, the intervention radiology team comes and secures the bleeding. And that's why you do a CT angio prior. When you do a CT angio prior, the IR team already knows where the problem is. He knows that this left upper side, right lower side, wherever there is this particular mass or there is this particular growth, I have to go there. So when he's doing the CT, the angiography is not going to just be shooting here. He'll be shooting exactly in that place to understand, okay, this is where I have to be. You understand? In the interim that the patient has got hemoptysis, what do you do? So in the interim, so you have a patient, now you have understood that you need the patient to go in for a conventional angiography to secure the bleed. What would you do at that stage? So the patient is in front of you, patient is coughing on blood, 200 cc's come, patient stable talking to you, okay, coughing. Such patients will keep coughing, okay, it looks very ghastly. They keep coughing because all that blood is getting into the alveolus. So as it's getting into the alveolus, this patient starts coughing and coughing. You will see the patient just coughing in front of you and expectorating, coughing, expectorating. It looks dirty. It looks like one of those horror movies, blood coming on here and there. It looks very dirty, okay. And what do you do at that stage? Patient is conscious, patient's blood pressure is okay, pulse rate will be fast because patient is having anxiety. Okay, what will you do at that time? What will you do? No, you can't do that because you've done a coagulation assay. The coagulation assay is normal here. No? So if the coagulation assay is abnormal, so you will still not, vitamin K is not something that is majorly. There's only one indication what you do in these cases because it's so quick. If the patient is having hemoptysis and there is a warfarin-induced bleed, then the first thing I would do is a prothrombin complex concentrate. This is what I would do. 2000 units of prothrombin complex PCC octoplex. We'll just give it 2000 units. Okay, we'll just give that 2000 units of octoplex. You may want to give vitamin K. Okay, but it's not going to work immediately. The prothrombin complex concentrate I will give fast. Okay, one dose for 2000 units, which I can repeat after 25-30 minutes if the PTT is still prolonged. Okay, the PT is INR's range. What will you do? So you're still in the question, what do you do? Coagulation factors are normal and the patient is bleeding. Is there any drug that you can use? Any drug? So tranexamic acid, how do you use this? So in hemoptysis you use it by nebulized format. In hemoptysis you would probably give 500 milligrams 3 times in a day nebulized. Okay, this is what you probably do. You can give an IV dose of 500 milligrams of tranexamic acid, but there are a few studies that have actually talked about giving tranexamic acid nebulized 500 milligrams 3 times in a day nebulized. Okay, which will actually give you some time before the patient goes down, right? Okay, you're faced with a condition. So this is very simple. So then after that you go for an IR and the IR does its job. So it's simple. Okay, but it becomes slightly complex and difficult when you have a patient who's now bleeding and is getting into distress. When he's bleeding and is getting into distress, what is the active role and how do you manage these patients? Ashok, how do you do this?
Sir, I will first give positions such that non-bleeding lung should be
Yeah.
bleeding lung should be dependent and non-bleeding should be.
So you are trying to preserve the
Preserve,
lung that is not. So the role of CT comes there. Are you understanding? You will not know anything. You will not know anything if you don't have a CT in your hand. Are you understanding? That's the importance of doing a CT scan. If you do a CT scan, I'll know, okay, this is where the problem is. So that lung has to be down, other lung has to be up. Are you understanding? If you don't have a CT scan to begin with, where and what position you're going to give, you don't know. Are you understanding? It's so difficult if you don't know, if you've not done your CT. It's absolutely difficult. Okay, what is to be done in these cases? Then what do you do? You want to secure the airway?
Yes, sir.
So how do you do this? And what is the difficulty?
Sir, in this patient, if I make this patient supine, that the patient means bleeding can come through the mouth.
So what do you do? What do you do? How do you intubate these patients? This question is very clear. Drugs, we know we want to preserve. You want to give drugs that will not cause hemodynamic embarrassment. The drugs that you probably want to use in this case is related to ketamine usually. Okay, why is it ketamine? Because it has bronchodilatory effect at the same time. It preserves the circulation very well. It preserves respiration. So that's why we want to give ketamine here. Okay, it doesn't drop the blood pressure. So I'll use ketamine here with a combination of a rapid sequence intubation is what I'd like to do. I'd want to give scoline. Is something I would use. Neuromuscular blocker I will use. Okay, I'll keep my emergency drug standby. But how do you actually intubate?
You can use video laryngoscopy.
No, you can't. So what happens in this case? If you have, that means you haven't intubated hemoptysis. Next time when you intubate hemoptysis, you realize that you will sweat. Right? It's very difficult to intubate you. It's very difficult for you to intubate a patient of hemoptysis. Extremely difficult because nothing can be seen inside. He is actively bleeding. So when you moment you put a scope, video laryngoscope is out only because you can't see anything. It just clogs it. So you never use a video laryngoscope in these cases. You use actually a normal laryngoscope. You have 2-3 people along with you, but the importance is how to use the suction. The trick over here is keep the suction inside. Open the suction first of all. In any case of hemoptysis, any case of hematomesis, open up the suction. Don't use it as the anchor. Yeah, because the bleeding is much more than 300 millimeters of mercury. You know, you're bleeding at a blood pressure of 120. It is like an arterial line. Okay, so at an arterial line, you can't use your small patla suction catheter and put that inside. It is not going to suffice only. It is not going to suffice. You need a huge amount of blood to come out. You know, you need a huge amount of blood to come out. You cannot use a small catheter. You are understanding what I am saying? So usually what you do in these cases is you actually put the laryngoscope, but you use the suction catheter without the anchor, just with the entire suction, and put it on the right side of your tube or the left side of your laryngoscope. So don't put it here. Put it on the other side. Okay, put it on the other side so that your vision is there. Okay, your vision is there and the suction is on at full go. Okay, remember this very importantly because you cannot intubate this patient unless suction is continuous. You can't say give me suction. Nahi hota hai. It's not possible. So usually we say keep 2 suctions ready. We say keep 2 suctions ready. One suction would be actually opened up with the anchor. Put that suction on the left side of the laryngoscope. And do a laryngoscopy. The suction is on the left side, continuously doing suction because buzz when it's coming. You can't take suction, do suction. You can't do that. Okay, and then you insert a tube and immediately ventilate this patient with high PEEP. Give PEEP and let the lung not expand and contract. Okay, if the BP permits, keep the PEEP on so that the lung does not open, close. That is why in these cases, if the patient is not being ventilated, you don't want to give incentives spirometry. It's actually foolish to give incentives spirometry. If you give incentives spirometry, what is going to happen? The lungs are going to expand and contract. The clot that is forming is actually dislodging. So we don't want to do this incentives spirometry and aggressive chest physiotherapy. It's foolish to do it in pulmonary embolism and cases like this, and hemoptysis. So we will not do incentives spirometry. We will not do, and that's the reason also that we don't want to give an expectorant. We normally want to give a cough suppressant so that there is no more cough. Okay, there is no more cough. As long as there is no cough, there is no problem. Okay, so there is no rocket science on hemoptysis. It's one of the most simplest subjects. It's very scoring. Okay, but at the end of the day, you should understand how to approach it. If you keep it simple, it is very simple. If you want to make it difficult, you can make it difficult. This is all about hemoptysis. Any questions on hemoptysis? Any questions on hemoptysis? Any more questions?
So now in this patient, we are going to do means embolizing first. After that,
No,
No.
we don't
CT
know.
angio.
We don't know. CT angio, if it shows a tumor blush, okay, if it is, now we will have to figure out whether that is in this patient whether it's a malignancy in the first place. Okay, in this case it's a probable malignancy. So in the event that it's a vascular tumor, we will first discuss with the CT person whether we can actually do a biopsy safely. If we can do a biopsy safely, we'll go for the biopsy, prove it. Then the treatment for that will be chemotherapy. Are you understanding? That's going to be treatment of that after PET scan and whatever needs to be done. Okay, but we will first prove it that there is a problem. The only way to prove it is by doing a biopsy. So if the radiologist says I can do the biopsy, there will be no problem. We do the biopsy. If they say no, there's too much of vascularity there, which is done. CT angio is done. We'll see it's vascularity. If there's vascularity, we'll go ahead and first embolize and then do it. That's how it's going to be. This is complete. So this is very clear. No, this case. If this case would have gone to hemoptysis, what you would have done? You would have put this patient in the left lateral because his left side of the lung is involved. Keep the right side out. Intubated this patient and sent him for a CT, say for a conventional angiography. Clear? Huh? Any questions further? Okay, stop this one. Vidya will start yours.